outside of what that law says. So I think and then I think the biggest benefit the Affordable Care Act provides to what I'm trying to do is that the Affordable Care Act makes people Medicaid eligible no matter whether they're, right now if you're an adult and you're not disabled and you don't have children, even if you have no income, you don't qualify for Medicaid in the state of Colorado. Under the Affordable Care Act, everybody will if they're earning less than 133% of the federal poverty level. And for Colorado, that's going to be an expansion of about 140,000 lives, for which the federal government will cover 90% of the cost. They'll do 100% for the first 3 years, and then they'll do 95%, and then they'll do 90%. So that means, to me, that the amount of money we'd have available from the feds to help finance our own insurance plan will be much greater than it would have been without the Affordable Care Act. So it provides a lot of benefit to us.
I think you still have the
question
to finish. Though I have a question.
So a lot is asked about community health centers. You know, community health centers are incredible in terms of what they can do and the price at which they can do it. They're very cost effective. And part of it is because I'm sure their mission is to provide care to as many people as they can in as respectful a way as possible. And they tend to salary providers. In the old days, it was seen as a less well-paying job, but with the way medicine's evolving, it's a better-paying job now. And they do it at probably about 2/3 the cost of a traditional clinic or provider. And so they do that while seeing people, disproportionately people on Medicaid and Medicare and uninsured. So I think by making everybody's life worth the same, this cooperative would give them actually more robustness and more financial security. Yes, ma'am.
Hi. So I was wondering about the number of people uninsured or underinsured. If everybody becomes insured, I can only assume the amount of people going to the hospital, to the doctor's office will increase. Well, now it's even harder to get into an office, you know, within a week. So I was wondering if you foresee the quality of care going down. We are actually all nursing students going back for our masters. And so working in the hospital, we see a lot of readmissions, and the cost of that is immeasurable. So do you foresee the quality of care going down because the number of people going to the hospitals and to the doctors? Or how would that affect us as healthcare providers?
So, you know, that's a great question, and let me tell you, first of all, that I get asked this a lot, what's going to happen, do we have enough providers if everybody has coverage? You know, they've actually done studies about what happens when people first qualify for Medicare, and the most expensive Medicare clients are the people in their first 2 or 3 years, because they have all this pent-up need that they weren't taking care of, and then, well, one more year and I'll be on Medicare, and so then they get it all taken care of. So you're right, there is a sort of first blush dramatic increase in utilization that then levels and normalizes. Two things, the idea behind patient-centered medical care, medical homes, and accountable care organizations is that it's in their best interest to keep you out of the hospital. And so in giving them flexibility in how they can provide for your care, they might decide that it's worth their money to have a nurse who every day visits people the first day they're discharged from the hospital in their home, make sure they have all their medicine, they know how to take it, and that they're doing okay until they're ready to discharge them to saying, okay, you're okay or safe to be in the community. Or maybe the nurse would say, I think this person will always need somebody coming in every morning to be sure they take their medicine, and then that job transitions to somebody else. Maybe even the health center decides they're going to pay their aunt to come in every day and make sure they take their medicine or whatever it might be. So that kind of innovation will happen. There's this great article by this guy named Atul Gawande. He's a surgeon in Boston, and he writes for the New Yorker, and it's called Hot Spotters. And it talks about how if you really take care of that really sick person's care holistically, you can can dramatically decrease access and utilization to health care and cost with that. And so I think the nice thing is that in Colorado we're already organizing into these types of healthcare delivery models, and so hopefully that will be further along by the time we're ready to implement this, so we'll have it worked out. Interestingly, in Denmark, when they went to having people's care really taken care of by a medical home, the number of hospitals they had declined from like 90 to 75, and it's going down to 40. Because if you do a really good job of keeping people healthy, they're not in the hospital as much. And right now, you make more money when people are in the hospital. In our new model, you make more money when you keep people out of the hospital. And so that build a better maize, get a smarter rat thing, the way to get the cheese will be to keep people healthy and in their home. The other thing in terms of access to providers, and you all probably, I don't know how much you've done in clinics or emergency rooms yet or not, but you know, I think we've lost a lot of our ability to just take care of ourselves over time. We've medicalized so many things that, you know, as a parent, your kid gets a fever and you're like, do I need to take them to the doctor? And so I think some of it will have to be around re-education and making, say, statewide available a nurse advice line where you could call somebody for help and guidance on whether or not you have to go in. But the other thing we've done is we've really sort of, providers have been very territorial in saying, well, you can only do this if you're a doctor, you can only do this if you're a nurse, you can only do this if whatever. And if nothing else, the experience of having a child with a disability in my family and knowing other families who have children with disabilities, I mean, who would have thought that people on ventilators would be living in their own homes? And that was a model we never envisioned 20 years ago. So what I envision as well is that we need each person to be able to practice to the full extent of their licensure. I know when I worked at Denver Health West Side, actually our nurses did a better job at managing high blood pressure than the doctors did, because they really spent the time that was needed to educate the person about the dietary things, the medication, the side effects, and things like that. So I think we'll see a redistribution of who does what and people being able to practice to the full extent of their licensure.
I have two questions. One is, I mean, you've talked about a lot of innovative ideas. They all sound great, but how will that happen? Who will make the decision to make these things happen? Is that part of the legislation or whatever? How will it work? My second question is, it is so complicated. You have done so much research and you have thought about all these details and you are able to speak to it so well. But is there a way of simplifying what the whole thing is about so that we can talk to other people and tell them?
So your first question was who will assess the design? You know, it's fascinating to go around and talk with different people because people really are very creative and innovative and inventive. And you'd be surprised at all the different models that already exist out there for medicine and practicing medicine and getting the needs of the public met. And so I think that the innovation is already out there and exists, and this will just speed it up by allowing flexibility in how you get paid and can do things. And that will sort of free up the whole creativity, innovation stuff even further. So I think we just have a lot of very bright, creative people out there already thinking about how can I keep my patients healthier, how can I keep the general public healthier, and things like that. So I'm not so worried about that. In terms of how do you explain this in an easy way, that's harder. And sometimes a person who's not so close to the inside can do it better than a person who like knows it as well as I do. The simplest way I can think of is to say that, you know, we know that we spend more than enough to take care of everybody, but we're doing it in a really inefficient way. If we could just collect all the money and be sure everybody got the care that they needed in an efficient way and save and not waste money on overhead and on trying to keep people out, we could all stay healthier. But the principles is probably the closest thing I can get to trying to be a simple thing. I think that handout was in there. And even that is, it's sometimes really hard for people to, I mean, it's a really hard thing to understand. I think most people have no idea, were like me and had no idea how healthcare was financed in the United States and how distorted of a job we were doing.
So, reading your white paper, the 4-page white paper, I have come to understand that it involves an individual mandate, your plan. And all Colorado residents would be members as such. In your discussions, particularly with the Republican side of the political spectrum, and with others, just with people in general, to what degree do you anticipate, or are you finding now, that would be an impediment to this being adopted in Colorado?